Well, thank you. Thank you very much for the chance to be with you. I'm excited to share thoughts with you. I'm also aware it's the end of a long day for you. It's beautiful outside, and you all would be healthier if you're out there walking instead of listening to me. So I'm going to try to be respectful of that. In the half hour I have with you, I'm going to spend some time framing things, and then I hope you just get some questions ready, and we'll have a little bit of back and forth before you take your break and celebrate the day. Yeah, my career past over almost 40 years has been spent trying to make healthcare better, improving care. We have some chartering ideas behind that. The Institute of Medicine in this famous report, Crossing the Quality Chasm, laid out 6 aims for improvement. And I helped write that report. I know them well. Safety, don't hurt people when they're in our hands. Effectiveness, make sure that we give scientifically grounded care. Patient-centeredness, let's return control to the people we're trying to help. Timeliness, don't keep people waiting. Don't have delays that are non-instrumental. Efficiency, don't waste stuff. And equity, close mainly racial and socioeconomic gaps in health status. And that was the canonical set of goals, the aims for improvement that have been guiding my work really since before that report, but at least for the past 20 years. Safe, effective, patient-centered, timely, efficient, equitable care. That'd be great. If you have a heart attack, you can count on it. If you break your arm, you can count on it. In about 2006, that set of goals got trumped. The ante went up, and it was due to 2 of my colleagues, John Whittington, who's a doctor in Peoria, Illinois, and a member of the IHI faculty, and Tom Nolan, who sadly died last month. Tom was, in my mind, the leading scholar of quality in the world, protege of Deming's. And Nolan and Whittington came to me one day, and they said, you know, that's nice, safe, effective, patient-centered, timely, efficient, equitable care, but that's not enough. Because healthcare is a repair shop. I mean, you're just waiting for the trouble. That heart attack came from somewhere. That broken arm came from somewhere. That depression's being caused. And they're really, you know, any smart system would regard its mission as including a second major set of goals, which is keep people healthy. They invented what's now called the triple aim, which you probably heard of. Better care, that's the 6 things: safe, effective, patient-centered, timely, efficient, equitable care, if you're in care. Better health for populations, so you don't need the care. And then they added the third, which is lower per capita cost, not through withholding anything. We're not talking about rationing. We're talking about sensible reduction of waste in the healthcare system. And that became the new canon, not just the 6 aims, but the triple aim: better care, better health at lower cost. Recently, as you probably know, a lot of people have added the aim joy in work, because you really couldn't get the triple aim accomplished from a depressed or burned out workforce. That wouldn't make any sense. So you can have it if you want the 4th aim, joy in work. So I've known that. I've taught that for years. I'm a pediatrician after all, and a lot of the kids I took care of certainly had the health and the care side to that. But then I became interested for a whole bunch of reasons in the past few years to that corner, that one that said population health. What is that about? And I began to encounter science that you know well, and I'm sure many of the speakers here today have referenced it. I apologize if I'm repeating what they said. But let me give you the facts. If you board, I was in New York City yesterday, if you board the D train in Upper East Side Manhattan, 85th Street Manhattan, the people walking above you are largely white. They're largely in suits or business dress, well-dressed. Their average income is about $180,000 a year, and on average, they're going to live 85 years on the Upper East Side. If you travel that D train about 2.5 miles north to the South Bronx, 165th Street in the South Bronx, everything's different above you. The average income is now way below $50,000 a year. The population is almost all people of color. The kids are impoverished. And the life expectancy is at least 10 years less. If you start out in Oxford Circus in London, where the same numbers apply, 85-year life expectancy, same as Japan. If you travel 3 miles east to East London, Star Lane in East London, the life expectancy has fallen by 20 years. If you're in Flint, Michigan, and you cross from one side of the city to the other, life expectancy changes by 15 years. If you're in Chicago, in the Chicago Loop, your life expectancy is about 84 years. If you go a couple miles west to Westlake, Chicago, your life expectancy is 16 years shorter. Something's happening here. Now, this has been studied by epidemiologists for a long time. We know a few things. One is that you can't explain it with the biologic variables. That is, if you look at cholesterol levels or blood pressures or rates of obesity, the risk factors we know about, they might pick up maybe a third, less than a third of that difference. The rest is what? Something is killing us, them. And it would be a legitimate question to ask, what is it? Whatever it is massive. And let me tell you how massive. I did a little calculation when I began encountering these data, and I think this is about right. I don't know how many of you are on statins. I am. A very popular drug, and sort of regarded in cardiology as sort of one of the miracles of modern medicine. We now know we can keep your cholesterol under control, and maybe the literature is complex and hard to interpret, but we probably can reduce heart attacks or maybe prevent cardiac deaths. The literature is squirrely, but the most favorable study of statins, according to the British Medical Journal, which wrote this paper a number of years ago, the most favorable study of statins says if you take statins for 1 year, on the average, you extend your life by 1 day. If you take statins for 20 years, on average, you extend your life by 20 days. A victory for medicine. On the D train, from 85th Street in Manhattan to 165th Street in the South Bronx, you lose 20 days of life in 6 seconds. If you are on the bus in Glasgow, from west to east, you lose 20 days of life in 43 feet of a bus trip. The power of whatever that monster is that's causing these differences in our well-being, it overwhelms anything we can do with healthcare. With $3 trillion of healthcare, something else is going on. And I knew that, but I didn't have a way to think about it. The stuff I want to share with you in a few minutes briefly is the work of Sir Michael Marmot. If you haven't read Sir Michael Marmot's book called The Health Gap, which came out in 2015, you should. It's not alone. There are many scholars. Julian Tudor Hart's work, the work of Harry Burns, the work of Douglas Black, and others. There's plenty of scholars out there trying to find out what explains what we now call the subway map, because these differences, the metaphor of the subway ride is pretty ambient. Marmot's book is a pretty useful summary of what the causes are, what the monsters are. Now, those monsters we have a term for. It's on your logo. It's social determinants of health. That's a pretty sterile term, but they're causes. Marmot calls them the causes of the causes, the things that make us sick. Marmot lists 6, and in his book, he summarizes the evidence of how we know this is a cause of causes, and it suggests some of the mechanisms that kill us early. The first is experiences of early childhood, very powerful. You probably know the work done at Kaiser Permanente and CDC years ago on adverse childhood experiences, ACEs. Here in Boston, researchers have called them toxic stresses. This is kind of simple. You take a kid and you ask, have you been exposed to any of the following things, 10 things in the ACEs score, like violence interpersonal violence in your home, substance abuse, a death, a violent death. There are 10 ACEs. A kid that scores 4 or more ACEs in very young childhood is going to be an adult with a phenomenally higher risk of both physical and mental illness. Double the rate of heart disease, double the rate of lung disease, 6 times the rate of suicide, 12 times the rate of substance abuse. Early childhood experiences are a determinant of well-being in later life. We don't know the mechanisms, but they're really powerful. The second category is schooling, it's education, especially of women and girls. Gaps in education are deeply associated with gaps in lifespan. Between the upper fifth and the lower fifth of education level in this country, there's a lifespan difference of about 10 years, about the same as that subway ride in the Bronx. You could say, well, that's because people who are sick don't get schooled. It's not, that directionality doesn't work. It's the other way around. And interestingly, there are countries that invest in inequality in children, that is through transfer payments, prevent child poverty, quite successfully. They eliminate the relationship between educational level and longevity. They still have differences in education level, but they're no longer related to how long you live. Equity and redistribution of supports for people, for young children matters. The third category is work. Some of it's just income. There is a relationship between lifespan and income. But it's also conditions of work. And there's really good evidence now that shows that work with meaning, work with dignity, work in which the worker in the workplace feels valued, is involved, produces longer lifespan. The quality of work matters deeply. This is beyond income and toxins, for example, all of which matter also. The fourth category is how societies treat elders, and I find this one particularly interesting. Societies in which elders maintain participation, have meaning in their lives, have loneliness avoided, as the prior panel was talked about. Societies that invest in that and communities that invest in that have much longer longevity, much better health status for everyone. That is, for reasons that I don't quite get, compassion and sensitivity to the needs of elders, just like that panel was talking about, is associated with longer life expectancy for the entire population. The fifth factor is a big one. It's what Marmot calls resilience in communities. This is everything else. It's the conditions of community that allow people to live safely and meaningful lives. I was in England 2 weeks ago in a very stressed community, a rural community, and we were dealing with health issues there. And I asked the healthcare workforce, well, what's making a difference here? What would make a difference? And they had no question. Everybody had the same answer: transportation. People can't get around here. They just don't have a public transportation system. That's a health-giving feature. That's a form of community resilience. So is housing. So is the food chain. So is food security. So is safety on the streets. And these are strongly associated with lifespan in communities, especially when the community has control over those resources, when the community actually feels efficacious. For example, in studies in Canada of indigenous populations in Canada, populations that have very strong local control of language and culture in the indigenous community have less than half the suicide rate of the populations that don't feel in control. And the sixth factor that Marmot throws in is he calls it fairness, and it is simply solidarity. It's a sense that somehow we're responsible for each other. It's a much vaguer characteristic, but communities and countries that through their behaviors evince a sense that we're in it together, that we're responsible for each other, that your trouble is my trouble too, have longer lifespan, period. Marmot regards inequity and the acceptance of inequity as the fundamental driver, not just of that feature, but of all of the above, of disparities in early childhood experience, education, workforce, and the way we treat elders, and of fairness in communities. So we know the monsters, at least Marmot does, and his book is convincing, and he's not the only one. You can read this literature as I've done now and say, we know the causes, the germs are clear, their names are known. What we don't have is a plan, is a way to tackle them, which some of you were asking in this panel before me. It's like we keep funding the repair shop, but never fix the roads. And it's as stupid as it could be in terms of, even if you're only interested in economic vitality, because everything I just told you eats away at the economic integrity of our communities. The dynamics of investment reveal the problem. Betsy Bradley, now the president of Vassar, formerly professor at Yale, did a fundamentally important piece of work, the best health services research perhaps of the last decade. Betsy studied countries with respect to the question, how much are they spending on health care and how much are they spending on social services? And the average profile in OECD Western nations is 2 to 1. $2 on social healthcare, social services supports resilience for every $1 on healthcare. We're the opposite. We're 90 cents on social services for every dollar on healthcare. The lack of investment in the causes of the causes is reflected in our distribution of money. You asked some of the panelists before, well, you know, who could change that? What's going on right now is that a $3 trillion delivery system invested in cathedral hospitals and high-tech interventions and the repair shop appears unable or unwilling to give up the money it has to devote to the causes of causes. It's a misallocation that is, at the moment, really hard to fix. There's only two options. Option one would be find the other money then, raise our taxes, do something so we can build those houses, get those buses rolling, give kids a fair shake in school, work on nutrition, work on the causes of the causes, or reallocate the money. And there's only one possible source for reallocation in American society today, and that's the healthcare system. It's got 18% of the GDP malinvested. That's the struggle we're in, which is how to begin to find the leverage, the tool, the will, the solidarity to say, no, let's work on the causes. And it's a hard, hard game. I searched in this research for healthcare systems that are making a difference. We have examples. We have historic examples. The University of Rochester is one of the sponsors here. Rochester was famous when I was a medical student. Rochester was a city that came together. Rochester decided to have primary care. And it took the corporations and the clinical structures and the institutional structures together, and Rochester invented a system of secure primary care for its entire population. It was a legend. People went to see how they did it. It fell apart, but for a while it was there, it was glorious. Today we have institutions that seem to be invested in dealing with the subway map. Rush Health System in Chicago has declared itself to be what's called an anchor institution. I'll explain that if you want, but Rush is on record saying we are going to take this 16-year gap between Westlake and the Loop and close it. They're going to close it 50% within the next 5 years, I think it is. They're beginning to declare some goals. Bell Health in Green Bay, Wisconsin is now deeply invested in building vitality and resilience in communities, working in the schools, the healthcare system working in the public schools to help train kids up to deal with quality improvement and improvement of community resources. We have really interesting early work going on in Kaiser Permanente, which I'm pretty excited about. The whole purpose-built community movement, which is all over the country right now. There are about 20 or 22 purpose-built communities in which community structures, sometimes but not always led by healthcare, are coming together to invest in these social determinants. So we begin to see things change, but we got a long way to go. Whether we're able to do it, I don't know. To me, it's all cycles back to solidarity. That's a word you hear often in Europe and other countries. You don't hear it here that much. I guess it's thought to be naive or un-American to think we're responsible for each other, but there's no other way. So let me stop there. I've left a few minutes for questions, and I thank you again for the chance to share some thoughts with you. Yes, sir.
Dr. Berwick, thank you very much for your service. You talked about Medicare for all, and would that help with solidarity?
You were asking me at a vulnerable time. I'm testifying at Congress tomorrow, Ways and Means Committee on Medicare for all. Yes, I believe it would. It's been a long journey for me, but I've come to believe that one of the greatest levers we could have for the kind of change and good sense that I'm trying to talk about would be to consolidate the money we spend on health and care into one stream that would be publicly accountable. That gives us all, give you in your city or your town a pot of money with a single payer in custody of that. You could set some goals. You could say, you know, we've got an opioid epidemic, we're going to stop it now. And if that requires moving some resources from here to there, we can do it. We don't have the leverage or the mechanisms for that kind of rational decision making about what we want to achieve with our communities and ourselves. Healthcare's got to change. We've got to move into the more person-centered views that we now know work better. And again, we need leadership for that. And I personally think that a consolidated public financing system would be would offer much more leverage. When I ran Medicare and Medicaid, I could see that. I could do that. I was responsible for the care of 100 million people. That was my job. And when I got word about something that was going wrong for the care of 100 million people, like over-sedation in nursing homes or infections in hospitals or over-institutionalization, we could begin to set some goals and then go to the caregiver system and say, how about helping? You know, can we do something that would help make better care, the AAA, possible? So I'm a fan. It's not easy. It's very hard.
Dr. Berwick. My name is Caroline Burchuk. I'm a physician at Commonwealth Care Alliance here
Oh,
in
great.
Boston.
I worship that organization. It's wonderful.
Well, we think very highly of you as well. I have a question about sort of health as an industry providing social services. So as at full financial risk for duals, we've done permanent supportive housing for seniors for decades. We've done medically tailored meals for decades. We are a social services organization that happens to have a health plan and care delivery network.
Masquerading as a healthcare organization.
Exactly. And how do you think about those lines as we reallocate resources? Who has the power and who's responsible for delivering them?
Well, you're my icon. I mean, you're doing it. I know you are, and there are other examples like that. And the question about payment is, I do believe that if there were a global budget system for care of a population, you could do that. And you could say, you know, it's food, not drugs right now. So that would help. But in the end, you know, we're in a dilemma. The resources are in the hands of the healthcare world. The insurers and the deliverers of healthcare. We've got it. We've got 18% of this gross domestic product. Nobody else has that. Nobody else has the right to raise our income 3% a year and call that a success. So we've got the power. We've got the money. So part of me says you got to give it up. There has to be a point at which we say and I believe this, with quality improvement, we can get all of the acute care done. I don't think we should deny a single liver transplant or heart transplant in this country. I think if you need advanced chemotherapy, you should get it. No part of me thinks that we have to or should withhold high-tech care when it helps. But discipline around making sure that what we do helps and matters to people would, I think, free up resources to allow us to focus on the inequities and the injustices that we're talking about. Now, when you go to the hospitals and say that, you go to the health system, their tendency, they'll have a program office on population health, everybody does now, but when you actually go in the C-suite, into the business of the place, they'll say, it's really not we don't really do housing. You know, we're not into transport. We don't, you know, inequity is bad, but we didn't cause it. So it's it's really bad, but it's not our job is still, I think, I think it's time to stop that. You know, if a new germ appeared for which we don't have an antibiotic, Ebola arrives, healthcare doesn't get to say, oh, we don't do Ebola. I mean, we're not ready for that, and that wasn't in the original charter. That's not our stuff. I'd say, are you nuts? You're here to preserve and improve health and well-being. So we've got Ebola. It's called inequity. It's called bad social determinants. And so it is a cause, and we just kind of been missing it, and it's time to engage. So I know that's preachy, and I don't have to run a hospital, and I know you've got to have a positive bottom line, but in the end, it's got to be our job to participate actively in it. I think the solutions do have to lie, in large measure, for a lot of these determinants in power in communities. They need control, because they know what to do. So there is a shift of power, and I don't really think healthcare should be delivering a community redesign. That's not our job. But hosting it, supporting it, funding it, working together for it, I think works. And you can see it. Cincinnati Children's Hospital now, thrillingly, you know, at least if they stick with it, they're saying, you know, there are 60,000 disadvantaged kids in Cincinnati. They're our kids, and we're going to work to help lead change for that population. We'll set the table. One more question, I think. I'm getting a 1-minute sign. Yes, sir.
I'm David Klein, and I ran Excelis Blue Cross Blue Shield in Rochester for 10 years, and I thank you for your service. You were an outstanding director at CMS. You know, I've been retired 6 years, so in some ways I have some immunity from the problems of today. I worry about the pathway, not the destination. I worry about absence of trust, which gets in the way of solidarity. I worry about incremental steps and the dislocations that take place as you work your way, through those steps. And I just don't see today, and it's frustrating, if not horrifying, I just don't see today when I look in Washington, look in Congress, and to try to get to the type of solidarity you're talking about, it becomes more of a dream than a plan. And my question to you is, when I try to bring it back to today, to 2019 and 2020, and you have to sort of think about a step or two steps that you would take that might eventually get us to the destination that you've described, what comes to mind?
I too am worried. Certainly, with the current federal leadership, it's horrible, and it's horrible to think about centering our nation's future on that kind of divisive, hate-filled ethos. I don't like it. I don't have an easy solution, but I'm concerned. My glib answer to your question, though, is really clear to me, and that's regions and localities. I trust communities. I trust localities. And I think if we can be smart enough to find a way to say to Rochester or Omaha or rural Kentucky, it's your game. You have the answers, and the right job for government and for payers and for leaders is to help you achieve for yourselves what you know you want to achieve. And we have ideas, we have models, we can tell you what they're doing in another city or another country, and we can give you knowledge, we can give you permission and resources. In the end, we need to co-invent the solutions with you. So I become a much more fan of what I call locality-based designs and changes, and I think it can happen. I'm involved with a wonderful project in Kentucky right now, just starting, called Launch. It's the Federal Communications Commission and the National Cancer Institute working together to solve a big problem in rural Kentucky, which is inadequate cancer care. They can't get the care. All because of those social determinants. Well, they now believe that proper use of the internet and connectivity, along with the sciences of NIH and the wisdom of the local community and the energies of the University of Kentucky, they can build a virtual cancer care system that will be world-class for rural Kentucky. I'm so excited about it. That's not relevant to what we have to do in the Back Bay or in Rochester, in Roxbury or Dorchester. Every community has its problems and every community has its solutions. So that's the best I can do right now with an answer to your concern. I got the hook, so let me just thank you so much for the chance to join you, and thanks for being here.